Well, we have a quorum, so I'll call the meeting to order. And make a note of members present, Dana Seandell, Ken Crandall, and myself. So far, Jerry Nielsen is not here, and Rich Rydell will not be here. I guess the next order of business is the Pledge of Allegiance. Stand correctly here. Time for the pledge. You don't even have to sit down. I pledge
allegiance to the flag of the United States of America and to the republic for which it stands, one nation under God, indivisible, with liberty and justice for all.
The public comment period, are there any members of the public that would like to speak?
Okay. Shirley Williams, and I understand the first of the year, we're supposed to be able to go on the computer and get a list of the prices of all the services. And Linda told me I could go to her office and she would pull up the information for me. They had trouble getting it up on the computer, and she said she would mail it to me. That was 3 months ago, and I still haven't received it. Sadie?
Yes, I missed it, but I will get it to you tomorrow in the mail. I apologize for that.
Sadie will get it to you tomorrow.
Should also be reachable on the website now without problems.
They had problems trying to pull it up.
Any other comments? Thank you. Linda, I thought you were going to make
I have a letter that was sent to me and the board president, and they wanted me to read it. The board. It says, to whom it may concern, over a year ago I moved in with my grandparents on the Lake Almanor Peninsula. One of my main concerns was for my medical treatment. I had several chronic illnesses, and I was afraid that such a small town would not be able to offer the constant and comprehensive care I would need. To say I was pleasantly surprised doesn't even begin to cover it. I have a connective tissue disorder among many other conditions causing me to fall and seriously injure myself frequently. I have complications with my internal organs and many other obscure issues. I've had to go to the Seneca Hospital Emergency Department on several occasions. Before coming to Seneca Hospital, I was always afraid doctors wouldn't take me seriously because I was in the hospital frequently. But at Seneca, I always felt believed and listened to. The staff is kind and compassionate, and I built strong relationships with the hospital staff quite quickly. I always felt that they took my care personally. They made me feel important to them. You have no idea what that truly means. The staff of nurses, doctors, technicians, and countless others in the Seneca family made me feel safe, listened to, and cared for. As important as emergency medicine is, and as much as I respect and thank them for everything they have done for me, one group has gone far beyond any expectations I ever had. Dr. Dana Ware and her team are the true embodiment of caregivers. Dr. Ware not only diagnosed issues I've been having for years that other doctors where I used to live could figure out, and honestly I felt they couldn't be bothered. Because Dr. Ware listened and was determined to help me diagnose a rare stomach condition that other doctors assumed I was simply exaggerating or making up. After our early encounters, Dr. Ware knew that simply throwing prescriptions at my various and frequent ailments wouldn't solve anything. So Dr. Ware used her vast knowledge of Eastern medicine such as acupuncture and moxie, as well as Western medicine to tailor a treatment plan that helped me exponentially. Dr. Ware is a champion for her patients, and we are all lucky to have her. We are also lucky, however, to have her support staff. Irene is so compassionate and works so hard to make sure that everyone is not only seen by the doctor, but are given the time they need and deserve. Mary, the nurse in the office, is so empathetic. She truly connects with people. She truly connects with you while she's taking a blood pressure, your temperature, and other various tests. These are truly remarkable people. I would be remiss if I didn't specifically mention the clinic staff, specifically Tara Crawford, who always greeted me with a smile and set me up with my telemed appointments. She made sure I knew my sessions were confidential and explained the measures she took to ensure my privacy. Shannon, phlebotomy, always talked and joked with me, putting me at ease. I know I'm very difficult to draw blood from, and no matter how long I had to sit there, I was never annoyed or felt uncomfortable. It felt as if I was catching up with a friend. I just happened to have a needle on my arm. I feel truly blessed to have been treated by the Seneca healthcare system. My family and I are moving away, and I don't think I will miss anything more than the doctors and nurses that have helped me throughout my last year. If I could bring them all with me, I would, but this area deserves the care and compassion that they have to give. They make a difference in this community, and I'm sad to leave them behind.
Thank you. We'll move along to the, any comment? No comment. We'll move along with the approval of the minutes. We had a special board meeting on March 25th. Those meetings are rather brief, and I'll accept the motion to approve them.
I'll move to approve those minutes.
Is there a second? All in favor? Jerry? Dana?
Aye.
Ken?
Aye.
And I vote aye. Has everybody had a chance to read the minutes for March 20th? They came out just a few minutes ago.
I'll deal with those for next.
You want to table them
I
for
think
next
so, just
month?
so we got a chance to.
Okay. That's okay with you? We'll approve those minutes next month. There were a couple things on there though that I wanted to touch on. On agenda 8, Ken Crandall asked Jake to see if there would be any additional costs for any upgrades. I suppose, did you have an opportunity to do that?
Yes, there won't be any additional costs
Okay.
whatsoever.
And then the HRG stuff, we can discuss that later. Okay, medical staff report, Dr. Ware?
There's appointments for, a new dietitian whom I've not laid eyes on, and then 2 telemedicine, I think they're both in Reno, in cardiology, and their applications are in order.
We have a motion to approve those.
So moved.
All three? Is it for all three things?
Yes.
Is there a second?
I'll second.
All in favor, Ken?
Aye.
Tina?
Aye.
Jerry?
Aye.
And I'll vote aye.
Sorry, this really for the speaker.
No, he's not here.
Oh, okay.
He's in Europe. Or on his way to Europe. Did you want to give a report on the orchard?
To her, TK had, wrote me this nice summary, so we, went to Orchard Hospital, which interestingly has always been a private hospital in Ridley. So that was kind of interesting. It's certainly a little bit bigger than, Seneca. And they've had evident CPSI for a while. And, the things, well, first of all, the emergency room module is not ready for sale. It is being beta tested at Orchard Hospital. So the templates are going to change to a thing called notes, and there's no date as to which time that will be presented, and we certainly couldn't see it. The problems were, there weren't a lot of positive statements, put it that way. So everything here is somewhat negative. So compliance, struggle with pulling data out of evidence, and that's certainly been our experience here. For diagnoses, how many patients do we have with type 2 diabetes, right? That seems like it would be fundamental to an EHR, and it's always puzzled me that that is not possible. The notes are still not live. We previewed it again in demo format. The doctor who was there bragged about his performance on Epic, which was neither here nor there since we're not going to buy Epic. But when asked how long it takes him in Evident, he wouldn't testify. Instead, he showed how he jumped to discharging a patient without completing a note. And some of the people who've used Evident in the past, their ER doctors have had to come in on an extra day to finish the paperwork, which probably doesn't endear Evident to them. In terms of T-systems, the people who used that reported that the doctors and the nurses were able to spend more time in patient contact than chained to the computer. And one of the things I've got to say that really irritates me is I spend a lot of my time running around after the emergency room nurse telling them I put an order in, because they don't know. There's no trigger anywhere that says there's an order sitting here. And they have still not solved that in the ER module from Evident, which is fundamental. Doctor satisfaction retention, none was attributed to EHR. The employees testified to screen freezes and errors, and it's cumbersome. It takes time to generate the report. So it was interesting to visit, but much less so in looking at the evidence system, and more so talking to the people about their experience with them. So.
Thank you. Where do we stand on making a decision here?
So we pulled it off his agenda because we didn't think we were going to get the order done timely. We're still waiting for Dave to give us their updated quote. T-System has given us their quote, so we'll be ready to present it back to this board at the next meeting.
So we put that on the agenda
We can
for
put
the
that
next
on the
meeting
agenda.
and make a decision.
And then the decision, whether to purchase right now, put it in the next budget, how we're going to look at that. So it'll be on the next agenda.
But there's some fairly significant concerns in Italy. So,
It depends on who you talk to, really.
well, I think,
It's just like
yeah. I mean, what was your sense of who you talked to? I mean, was there this discontent widespread? This kind of...
No, I think they were very fair. I think they were struggling to be fair. So I asked the nurses who were running around working that day, how do you know that there's an order? And they say, oh, we just check frequently. Well, really, I mean, that means you're sitting at a computer, not out doing something. And I think they have a 5-room ER, so it's obviously bigger than ours. And what it is that only certain people are beta testing this program. So not everybody has an experience with it, but everybody has experience with Evident. And
Yeah. Do you know how long the testing is supposed to go on?
I do not know. Do you know, TK?
They were hoping to release notes this summer.
It would just be nice to see the work is done to correct this before we make the decision as to how effective some of that's been.
Well, I will tell you, when we, Takara organized the 4 presentations, Evident was 4 on 4 on Bob.
Yeah.
And I haven't changed my opinion of it.
And it sounds, as someone who doesn't work in the ER anymore, but I do work in the clinic, it sounds like the same problems that we have in the clinic are present with the module in the emergency
Right.
department.
Right.
They just don't fix it.
Well, I think their thinking is, do you know what I mean? I think that's what their thinking is. And the doctor who was there that day was, regardless, Korean, and he said that he had used Evident enough. He was the guy who was very fast on Epic, but he used Evident enough to where he could kind of understand the personality of the person who designed it. And I thought, not me. I'll never get there, I'm sorry. So he may have had more of an in than I have with it, because I don't find it remotely intuitive or helpful in ways that an EHR should be.
And Dr. Mellon just came in as our emergency physician medical director.
Yeah.
Sorry, Dr.
We were discussing the Orchard visit.
Oh.
Dr. Ware was updating us on her experience there. Do you want to add any comments?
Well, just by way of introduction, I've spent 43 years in emergency medicine, 20 years in the Navy, and 25 years at a level 2 trauma center, and for the last 2 years a level 10 doctor, and then now permanent here. So I've been exposed to about a dozen different EHRs, and I've also felt that both in the Navy and in the locum tenens business here, your guess at whatever new command or place you're at, you kind of use what's there. And so I used Evident at Catalina Island for a number of years, and I think it worked well for them in billing and in-house usage, but the family doctors refused to use it in the ER. We just used a paper system and copied it because it was so cumbersome, had so many clicks, it was pretty much not very possible to use. And then eventually things changed there, and they, long and short of it, we got UCI, University of California, everybody to come in and take over the ER part, and they likewise had a similar experience with Evident, and they got out of it right away, got their own system, a theme in place, and so needless to say, the past experience hasn't been good with that. And then as I come across it here, I used it, you know, I've gotten adapted to it, but it still is cumbersome, has lots of clicks. So when I heard that the visit down south, that they were having a new system of Evident in place, we went down there with that in mind, and again, just trying to have an open mind to it. But actually, in actuality, they did not have the notes portion in effect, and so you couldn't actually see it, any improvement or how it was working better, because they're not actually, they're just beginning to implement it. So it wasn't a very useful visit. I might say EHRs in general, sometimes they arise out of an urge to get a facility up in speed with billing, and I think CPSI or Evident came into existence that way. And then other things have been added on secondarily. But the T system was put into place for one reason, and that was to cover all the issues, to provide quality and maximize charting in the emergency room situation. They have decades in use as a paper chart, and then they created a digital one. And frankly, that's your best bet for maximizing billing, maximizing compliance, maximizing quality, because it was based on the chief complaint of what the patient presents with, and brings in and forces the physician to acknowledge things that we all should be doing when we're charting on a patient. And I don't know if you've introduced this or not. But
Oh, we did discuss the visit,
Okay.
not the testimonial calls.
Okay. So what you'll find is they talk about it more, the compliance, the left without being seen, all those things improve with that system. And so the long and short of it is we didn't get much out of the orchard visit because they haven't actually implemented it with the physicians. And that's the bottom line.
So, just a comment. My experience with trying to help there is promises made are not necessarily promises kept. And I always get into this, there's this gray area to, we're going to fix it, but to whose level of satisfaction? To your level of satisfaction or to their level of satisfaction? They say this is good enough. Are we necessarily in agreement? That's where I think it's really fuzzy. I'm not quite sure what we do with that, but my experience has always been that they say this is good, and you know, end users are
with no offense,
time consuming for us.
With no offense to programmers, trust the clinician. They're the ones that have to work with it every day. They're the ones that have to work with the patients and spend time and divide their time between working on an EMR or seeing a patient and spending time with them. So if you've got that kind of debate going on, I'll tell you, trust the clinician every time, because they'll tell you the truth and they'll tell you what's best for the patient and patient care.
I actually agree. The question that kind of raises, though, is when you get to that point when you're not satisfied and they're saying this is our best product, you want them to work on it some more, who bears that cost? You know, you're saying, go go back and fix that some more, we're not satisfied yet, who bears that cost? And that becomes a challenge.
So this will be on the agenda to hopefully make a decision at the next board meeting.
The comments that where you are in favor of the system, were you talking about CPSI or evident, I can't quite, is that right?
No, there's absolutely no equivocation on my part. The T system is far better in the emergency department by leaps and bounds over what Evident has to offer. And I have nothing to bring to, you know, I've used them all, and that's the one that'll give you the best bang for your buck in terms of quality, legally safe documentation, maximizing billing. Physicians are horrible at coding, and they're not that great at actually documenting well. But if you have an EMR that's designed for the area involved, it will force the physicians to give you a much better chart, medically, legally, quality-wise, and maximize your billing. And of all the dozen or so I've used, I think T-System does that the best. I have no stock in them. I have nothing but my clinical decision-making here to say
Dr. Brown,
that.
if I can interject, I believe that statement that you just made for the providers is equally true for the nurses. The nurses go to school to be nurses. There's not a separate course that they take in coding, and T-Systems addresses that need for both the physician as well as the nurse, whereas on the Evident module, they are enhancing notes, and that will be pushed out to the physicians first. It's their intention to get it to the nurses, but that's somewhat behind in development. And I don't have a time frame as to how quickly they'll bring that up to speed, but I do know they're not coming out to both parties at the same time for use.
I think this will be on the agenda for next month, and we'll hopefully make a decision at that time. Hopefully we'll have a full board here. Okay, Steve, do you have a financial report?
Talking about the month of March 2019, ninth month of our fiscal year. For the month of March, we had a net loss of $268,576, as opposed to a budgeted loss of $169,554, or a negative budget variance of about $99,000. The negative variance was comprised of two areas, two-thirds of it expenses, operating expenses, and a third of it other operating revenue. When the total patient revenue for the month was almost right on budget. We were just a little bit slightly positive, $7,000, but the outpatient revenue was positive $30,000, but there was some ups and downs, and a lot of our positive variance came from the emergency room and the ancillary services supporting emergency room patients and services. On the inpatient side, we were under budget both for the acute and for the nursing home. The nursing home just being a function of the number of residents that are down there, and acute, the number of patient days. But almost all of that was offset by our swing bed patients and our swing bed revenue. Just one thing of note, if you flip to the second page, at the top there in the revenue analysis in the first, not a quadrant, but it's kind of first group there, the actual month. First column in is the actual revenue for the month. The second column in is the month-to-date budget, and then third column is the variance. The fifth line down, inpatient revenue ancillary, this is all of the ancillary services associated with acute, swing, and long-term care. There's very little ancillary revenue associated with the long-term care. But you'll see that our ancillary services were negative to budget, and this is indicative that we had some swing patients that required much less ancillary service than our typical swing patient, and we'll talk about this a little more when we talk about the accounts receivable. But again, overall, the patient revenue was right around budget. There were some pluses and minuses as I kind of laid out. The adjustments to revenue were very close. The 48.5 were the adjustments versus a budget of 48 adjustments. Lower number the better. Yeah, patient revenue, higher number the better.
Steve, regarding the swing bed, it looks like, maybe you can talk about that a little bit more in relation to the ancillary, because it looks like we brought in about 3 times more than we expected for swing bed, and yet the ancillary is down, so pretty significant.
Yes, and it's just, again, indicative of the amount of ancillary services demanded by the one swing bed patient in particular.
Steve, in the occupational therapy building, where does that show up?
It would be, the occupational therapy billing would be an ancillary service of the inpatient revenue. And we've kind of talked about this, and we'll probably have more discussions as we talk about expansion of services or whatever it might be, that if you look at our investment in occupational therapy or therapy services, at least at this point, and then you look at our return on investment, it's not a dollar for dollar thing. The revenue that the occupational therapist generates for us is only part of the story. The fact that we have occupational therapy allows us to accept these swing bed patients, which then allows us to bill for the bed, allows us to bill for the other ancillary services that the swing patient will receive. So it's a huge benefit, and I know the thing that triggered it is occupational therapy. We get focused on that, and we talk about upstairs and things like that. But it's the ability to have these, be able to care for these types of patients and then in turn bill for their services. Expenses. So March is my favorite month. I think this was the first one I did by myself last year without John. And I looked at it, oh my gosh, what is going on here? When we have 3 pay periods occur in a month, although we only record the number of days in a month, and we adjust the payrolls based upon the number of days in the month, the way that we record certain non-productive expenses. So each pay period, all the employees, all the benefited employees that earn time off, we get different amounts based upon longevity, and at least for the PTO, not the sick. And so we record that as an expense and record that as a liability, because if the employee leaves, we'll pay that out. So what we do in a 3 payroll month is we record that entire PTO liability, regardless of the relationship to the number of days in the pay period. And so it just adds dollars right on top of our actual expense. The other thing we do is we record certain employee benefit expenses, workers' comp being the main one, the employer's share of employee benefit expense. And so that's what happens in March. So next year when we do the budget, we'll visualize out or project out what's going to be the 3 payroll month, and we're just going to put more budget in there. It's that simple. At the end of the day, it's the same number. Now, the only thing that can also affect our expense to budget is when we do our budget, we anticipate that employees will use a certain amount of their PTO, their time off. And if they don't use that PTO, we're paying their salary, and we're in certain departments, we're paying their wage, and then we're paying their benefit on top of it. If somebody takes time off, we're just paying, we're just basically recording one expense is the salary. In the 24-hour departments, we're always going to get hit for 2 no matter what, because when someone's off, someone has to cover that shift.
And Steve, let me interject. One of the issues that we've been, not we, but healthcare in general, anybody who goes through the 12-hour shifts are looking at is it allows the employees the opportunity to not use their PTO because they can schedule their shifts, their 12-hour shifts such to where they can get anywhere from 4 to 6 days off in a row and therefore not use their PTO because it's a regular time off and build up their PTO. And if it's an organization who allows the employees to cash out their PTO, then they're using it in essence. Because, and they earn it, I'm not saying they're not earning it, but it's just how you can use that PTO. And it's something that has happened with any of the 12-hour industries.
So I think what's coming out a little bit is as we go along through the year, certain things, you know, we just have to be a little, if we want a true representation, if we want a true analytic of the month, we're just going to have to be really detailed on how we do the budget and where we put certain expenses so that they time right with these types of occurrences. The other thing is that we've found, and we started the budget meetings with the department managers for next fiscal year. One of the things we found out about contract labor, and we've kind of alluded to it in the expense narrative, is that unfortunately there's not always a magical switch or a switch that we flip when we go from contract labor to employee expenses or employee labor. That means is that everyone, no matter who they are, they have to get oriented to Seneca hospital practices, Seneca healthcare practices. With the case of bringing in CNAs through our CNA program, which is fantastic and hopefully will be an immense success, ultimately, is these are new grads, and their orientation period is multiple months. We're very fortunate to find a relatively new RN that we're very excited to have here, but again, her orientation period is going to be a little longer than a experienced RN that comes in, and so that's just, I don't know, break out the crystal ball on that one about what mix of new grads, less experience, more experience, and the timing on the timing on bringing them to where there's not what we call shadowing, and basically you're paying 2 people until they're at the point where the nurse managers release that person to work the normal staffing. The other thing is that it's just absolutely clear that contract labor is going to be something that we're going to be with for a while, forever. And we will be venturing into bringing on employed radiology techs, which will be nice. Right now, that's one of our variances. We lost 2 people in radiology, and we've been employing a contract tech full-time. The good news is that our efforts to bring providers such as Dr. Mellon here to be under contract with us. We finally brought our ER average hourly cost down near to budget, which was a fantastic achievement. Now, if you want to be fair about it, we could be amortizing the buyout fee against that, but whatever. We'll, you know, it's going forward, it's good. In the month of March, we only had one day, one shift that was done under a locums arrangement. Everything else was done with Dr. Ware and our new contracted physicians, Dr. Dunn, Dr. Scott, and Dr. Taylor. So that was a really good thing. But what continues to hurt us is employing locums, nurse practitioners in the clinic. And then we talked about that in her CEO update. So if I could just stop there for just a minute. There's questions on it, we can talk about it. But there's, you know, as we look to expense savings in the budget, there may not be a lot there. The only place that we can, where the opportunity lies for expense saving is to bring providers in at this targeted rate that we have at their specialty. That's really going to be the key to bringing down this loss and bringing down the variance, at least from the expense side. Going into supplies, as I've mentioned, we over budgeted on the 403B, 340B pharmacy program. We got really good. This is the stuff that comes out in budget discussions. We found out, or I found out, that our local pharmacy doesn't take Medi-Cal, and that they'll go to Susanville or they'll go to Greenville. And so our contracted 340B manager actually stopped in Greenville when he came for a site visit, and what we may be able to do is, what we should be able to do is get him in our program, and we'll get credit for that, and that could be a pretty decent enhancement. It gets really difficult when we go into a town like Susanville, because you've got basically like Walmart and Walgreens and whatnot, and it's a lot cleaner when you have the local pharmacy. So there might be a little opportunity there. The rest of the stuff's pretty straightforward. Questions on expenses or revenue? So I'm going back to the first page. Under additional information, it did say that the days of cash on hand decreased from 87.2 to 58.2. We made the intergovernmental transfer for the rate range program. And the thing to note here is that is correct. This was the fiscal 17-18 program. So they're a year behind. So provided we get approval, which appears to be the case, that we're still looking at possibly, we're looking at sure one in the next year and maybe two in the next fiscal year. Right now on the rate range, we made this transfer of $1,275,000, and we're going to receive back probably in the next 2 to 3 weeks $3.5 million. So we're going to net, simple math, $2.3 million off of that. We also have made a hospital quality assurance fee, IGT, it was in the mid-200s, and we're set to receive $588,000 same timing, anytime in the next couple of weeks. Yesterday, we made the most recent prime grant, IGT. It was $337,500. This is not in your materials anywhere. And we'll get back $675,000 again in May. And then next Friday, we'll make one more transfer for about $275,000 and get back $550,000. So in May, we should be receiving almost $5 million. You know, it's good news, bad news, or good news, something news, because the cash just absolutely strengthens our balance sheet, allows us to even consider something like T-Systems or Evident, but it is still masking our operating loss. and it's something that we have to solve somehow, sometime. But
Steve, where do you show, that money out? So I'm guessing if you're doing it on, 5 million, you had 2,500,000 about go out.
it's on page 2, under tab B, page 2 of 7. The whole IGT activity is summarized down below, but gross, if you will. It says here, outgoing, incoming. But the way I did the budget, and I won't do it next year, I just tried to separate these things, or try to get our bottom line to where it was reflective of the net amount, not the gross amount, the way that the auditors require that we report it. So I'm reporting the net amount up there above in the 35 through 40 there. So the net amount, that's how we budgeted, that's how it'll get recorded. But down below is the net effect. I'll figure out a way, I think maybe I'll do the financials the way the auditors do, where we put the gross amount up above and then we have a below the line adjustment. But one of the things is that we have 2 programs, the Hospital Quality Assurance Fee and what's called Assembly Bill 113 that we'll be making the transfer for next week. There's no guarantee of these amounts, and it's a very, very difficult process to project if the programs will be approved and the amount of it. So it's I don't know. It's maybe one of those things where you don't budget for it, and when it comes in, it's a windfall. But it's terribly difficult. Whereas the rate range is a little more predictable, and the crime grant is completely predictable because they've already identified the pool of money, and based upon how we do on the measures, which actually I should have said something here. I'll say it again next month. Is that we were scheduled to this demonstration year 14 was a $1.2 million a year, which means that we would get the $1.2 million, but through the transfers we put up $600,000. We're getting $675,000. We scored perfect or met all the measures, and because of the way the pool works, sometimes there's some extra money if there's not participants, but we received more than what we were anticipating, so that was a great thing. And that $75,000 is a bonus.
The programs that are a little less able for us to predict, those tend to be lower in overall impact. Is that right?
They're smaller dollar amounts, but they're still, the net can be as high as $500,000, somewhere between $300,000 to $500,000 net each of the programs. So.
And your hesitation is with whether we should actually count on getting that money at all, or whether there's a low end that we can budget toward? Or is it buried in the program?
Yeah, there'll be something when I meet with my peer group next month. I'll put that out to everybody, and maybe the people that really babysit the programs have a better idea of what's fair, what's reasonable. But you know, I guess if we just stick it below the line, it doesn't matter anyway. You know, if it's down at the bottom here, then it's kind of a non-operating thing. But traditionally we put it up in higher.
Which I think tends to distort the picture.
And it can even get have consequences as much as Little Wagner's incentives, you know, if we're using operating margin. So we can discuss that. Hopefully I can bring a little better answer to you guys when we present the budget.
I used to hear what your peers are saying about it too.
But Steve, I came in to see you, we talked about is that gonna come up in budget where we try to even it out more so that we know, okay, we can anticipate that we're probably gonna get this much. We better save back from what we got before, so we get closer to, spending what we are.
Yeah, absolutely. Thing is we're probably, by the end of the year, we're probably gonna be sitting on about 130 days cash on hand. That's a lot. That's a significant amount. That may be a good time to really, as we've discussed, just put something away. I mean, just literally say this is there for whenever. But the other thing is that when we budget, as you can see, rate range 17-18, that should have been done a year ago. It was also anticipated it would be done January of this year, first quarter of this year. So as far as trying to put budget amounts in there by a month or something like that, that's also a challenge. But you know, that's clearly explainable when we do what we do.
Well, I wonder if that just needs to be, annually inspect this one, this program, this program, this program. And keep track of where that's at, rather than
Okay. All right, so revenue cycle, last thing is the gross accounts receivable came down a little bit, as did the days. One comment I'm going to make in talking about, going back to the revenue discussion about swing bed, that particular patient is faces discharge challenges, and so we've been unable to bill for any of the stay. That patient alone has about 4.5 days of AR alone in their outstanding balance. So, to be fair, that knocks 53.2 down to 48.7. So things are improving. We'll talk more during the contract thing, but we're still not without our major challenges. So
it's like they're starting to pay more attention now.
our meetings are getting bigger. They have more people on the other end of the phone.
Okay. Anything on the contract, Steve?
sad story is we have to do this. So if you guys have any questions or you want me to explain anything or that, I'm happy to do. One thing I would point out is on the second page, we came up with these measures. Days in AR are a pretty simple measure, but I think they're indicative of performance. So the way that they did it is that if the AR days are greater than 49 days, then they get a decrease. We take 0.25% of their invoice, $40,000. It's a few $100s. It's something. But the thing that's significant about what March would happen is up at the top when it talks about the AR days is that Seneca's piece in this, it's not all HRG. We have to keep the average unbilled days at 5 or less in order for this metric to apply. So, so in the case of March, the AR days, the unbilled days were at 10. So this would have been a no change or not applicable, because we just discussed one patient has 4.5 days by themselves. So without that in there, it would have been really close. And this is good, because this puts a good onus or whatever onto us to get our claims out, or our accounts out to them to bill. That's about the only thing I would talk about.
Well, talking dollars, what kind of incentive, like if they were to meet the higher measures on this? Just approximately, I just was curious if it's, we're talking thousands or talking. I'm just wondering how much of an incentive.
It's not much. It's not, but I mean, so their average bill is maybe $40,000, and so 1% is $400. So it's not much. I think what it's going to do more than, it's not going to create a financial penalty. It's going to create a performance penalty then. And if they don't meet it, then they're saying, here's the contract. You didn't meet the contract, so why are we talking about another renewal or whatever it is?
Fair enough, I did notice later in their report that the language has definitely changed and tried to be extremely rosy this time, so I said that they're paying attention. On the outset?
Yeah, we deal with numbers, not words.
Steve, how come we can't get out of contract? Is there, if they're not performing what they're supposed to do?
Well, to be clear, and I think those with history here will say that this group of HRG, or this time with HRG, is probably the best that any of them have, and their numbers are pretty reasonably well. It's just one of the reasons that our numbers are as good as they are is the amount of time that the staff here spend monitoring this and pointing things out and working with them. If we didn't do that, our numbers would be way worse. But the biggest reason that we can get out of it, but the biggest reason that we wouldn't is there's probably not a better replacement. And that's what we'll be looking at. I think when we get into the fall after a few months, if we're not getting any better, then we're going to start looking at some alternatives. And as we go into the 2020, we'll be seeking proposals and talking about it. One of the alternatives, of course, is to do it ourselves, and then that requires us to have the people there.
We've been there before.
Well, it's hard, and so we're hoping this works out, because it's good for them and it's good for us.
So the board's going to have to make a decision on this. Yes. Is there any comment from board members? Linda, do you want to make a comment?
No, I think Stephen and his team has been working really hard with HRG to hold them accountable, and this is just a one-year extension, it's not the 3 years, so it gives us time to really evaluate further and see what we're doing, so.
There aren't a lot of good options.
So it's not, that's the problem.
So, anybody want to make a motion to accept this?
So,
Second.
Second. All those in favor? Kim? evaluation criteria, a never-ending subject.
One of the things that I do want to say is I sent this off to the attorney for review as well. We wanted the track version, so we put the track version in, which is very hard to read. I sent to the attorney both versions. He is looking at it to give his suggestions, and what I told him is you need to look at this not as this is Linda Wagner's appraisal, this is the appraisal program for Seneca Healthcare District CPO. So they're looking at it in that manner. One of the comments made was that the attorney would like to see a more objective evaluation instead of the subjective. Did like the incentive piece, and what I did was made a copy of a non-track incentive, so you can see a little bit easier.
On track.
Yeah, and then, one of the things that when we met, Dr. Walls and Ken and I met, we had Steve in there at the time when we were trying to figure out that, method for the operating margin, and what Steve had suggested is let's wait on that one until we can come up with a better number after the budget process. We did come up with that 6-month average on the 85 days for cash on hand. So it's still a work in progress, but the attorney had suggested that we look at it and try to figure something out from this so that, again, it could be more objective.
So, just in response to that, Linda, I think, you know, Dr. Wells and I have had that discussion about parts of it are subjective, acknowledge that, parts of it are need to be objective, but there are some things that are very subjective in nature. That's why we had the board to look at that.
Exactly.
So your review then, that was supposed to take place in what month?
The incentive, the first half of the incentive for 2019 was due last month, and that's what's on the agenda for this month. Then the annual evaluation is due in September. And then the second half of the award for the incentive is also due in September. So the issue would be is when we get into close, the incentive that was due in March, what is to be awarded?
One of the things that came up at the last finance committee meeting, Rich brought this up, was under financials here. He would like to see something worked out whereby the budget, as Steve has mentioned, minus all of the grants, be used also in an evaluation.
And that would be a piece of that operating
Yes.
margin that we talked about, and that was why it wasn't in that one right now, because we didn't have a number.
So, Ken and Dr. Walls, all the changes that are on here to the form that you guys have put together, are these changes that you made? Or who made these changes? The brown and blue?
We talked about it at that meeting that we were at.
All three of us had a meeting. Ken and I came up with the original suggestions, and then the three of us got together and had a meeting to try to put together a plan that would apply to the CEO position regardless of who is in that position.
Okay.
So, part of this, I think it's important to mention that there is just a performance evaluation, and then there's the incentive piece, separate entities, and our conversation went to some type of minimum standard for the performance evaluation before an incentive is even considered. So it's like, you know, you don't need before you be considered for an incentive. Teacher means speaking.
And one of the issues with that is, so you would have a performance evaluation in which the in 2018, it occurred, there was, it was approved, performance was accepted. So then therefore the incentive for 2019 would be acceptable. Because that's what you have to look at, this evaluation is this year, and then you award the incentive for the following year because it's in a two-half piece. So that was one of the questions that got brought up as well.
I think this is being made way too complicated.
I don't think it's, if you've never been in a classroom, it's very difficult to be completely objective when you're grading somebody. It just, and there's a grammar area, grammar error on the first page.
Well, there's going to be, because this is the draft version, it's not the, and it's draft, and it's still under process.
And I also wanted to comment too, under the evaluation process, it talks about setting up a CEO evaluation committee consisting of 2 board members, the HR director, and the CEO. And my first thought is that I don't think that the person that is the subject of an evaluation or their direct report should necessarily be part of the committee. I think they should have input, and whoever's on that committee should go to them for input, but I don't think it makes sense for them to be evaluating themselves.
Comments?
So are we holding off on providing any more feedback on this?
No, you can still provide feedback, and I'll send it off to the attorney.
And I appreciate Dana's comment. Or evaluation.
I think the big area too that still has to be worked out is the scoring. Is how much weight to put on each.
I had sent a suggestion out, I don't know if you saw it, kind of copied you, but no, I can't copy both of you guys on for the percent weights.
We included
I
that.
included that.
Yeah, we included that at the meeting we had.
Did it go to all the board?
No, I can tell you what my suggestion was, if you want to hear it. In the sections.
Could you email it to me?
I can.
Everything I can give it to you.
Thank you very much.
But I didn't see yes.
Go ahead.
Do you want to mention that here now?
Yeah, we can if you like. The first section, I think, was I'm kind of lost in this.
The headings are, yeah, on this copy, the headings are not quite,
So I think quality draft.
Well, it's because it's the draft version,
Yeah.
and I was requested to give the draft version, so, that's why it's really hard to read.
is,
So my suggestion had been for, I think it was 25% for quality and patient safety.
can you give us a?
Like this.
I'm on, there's no page number.
Scoring, go on.
Versus the last one?
It's the third page. Third page.
I'm just going to your
Scoring.
overall
There you go.
Yeah, so I suggested 25% weighted toward quality and patient safety, 25% toward financial leadership, I think 20% for the staff relations, and then 15 each for the community partnerships and the last section, youth leadership. So 25, 25, 20, 15, 15.
I think that goes to the members.
No, that's all right. Yeah, that's all right. So that, I don't know if you all feel differently about how those categories are weighted, that was just my suggestion.
Well, yeah, I certainly agree that quality and finances are the two big ones. And they should serve as a weight.
And then I felt like the medical staff relations was very closely tied to that, so that's why I thought that perhaps should have close to the same to come out.
If you would like me to send an untracked version, I can do that. Actually, Monkey, did you send this to them email? Did you? Sorry. So if it was sent to you an email, you can just go into your Word document and untrack it up there. But if you said if it was a PDF, you can't untrack it, so I can send it to you a Word document where it's untracked.
Yeah, this is not what I'm at, I'm sorry, it was right here.
Oh, no, that's fine.
So let me ask, so the blue versus the brown, can we talk to when those changes are made in my phone, just so that I have an idea? In the track changes in two different colors?
Sure, it was, during the meeting, before the meeting, during the meeting, and then after the meeting with the comments.
So when you met and the three of you were together, it was blue?
I think it's the brown, actually, wasn't it?
It was the brown, and then after we were done, and I had taken, because we didn't do it while we, I commented enough on the computer to do those changes while they're talking, so the green was after, what was agreed upon after.
Thank you.
I guess you got it.
We keep doing it, green.
So I'll send you that untracked working as well.
So, refresh, this is talk to council now?
Is it possible that we can finish this next month so that we can go ahead and sign up?
I'm hoping so.
When do you think it'll be back?
I asked him to expedite it, so within a month.
I really would like to not get it back like 2 days before the next board meeting.
So that's what I'm asking.
You're asking 2 days before the next time.
No. Yeah, no, I've asked him to get it to me within the next couple of weeks.
So that'll be on the next agenda also.
Yes.
Moving on to the facility assessment tool.
So, you saw this last month, and what you saw last month that there was questions over was the worksheet that, Curdy had been working on that shouldn't have been a piece of that tool. So you have the tool back in front of you without that assessment piece. We did have survey, and the surveyors passed it and thought it was fantastic. But we still need to improve here. We were able to show the minutes that the board looked at it and had the questions, and that it was back here. So, like I said, the surveyors thought that it was fine. And then before you, well, I'm going to talk to you about the survey here now, or the CEO report, but.
The CEO report.
Okay.
So we have to approve this?
Yes, please.
Is there any discussion?
Well, I've got questions, but they're basically mechanical about the way it's going to go, so.
This was the state's template. We didn't have a choice on how, no. We had to follow their template and put it as they wanted it.
Well, let's grade them on how they.
Yes,
how
please
they
do that.
Okay. I guess if there's no comment, no comment necessary, I can move that we approve or accept or read the facility assessment tool for Seneca Healthcare District, SNF.
Is there a second to that? All those in favor? Ken?
Aye.
Dana?
Aye.
Jared? And I vote aye. Okay, another fun thing, the compliance plan.
Yes, Sadie and I had asked, I had said last month, we went to the compliance training, and I do want to say that Sadie and I both are now certified compliance, healthcare compliance experts. So Sadie put the compliance plan together. Sadie is the primary compliance officer, compliance and privacy officer. I'm the backup. So Sadie, you want to talk about the plan?
Sure. This is the first step in the whole compliance program. Mainly just trying to put Seneca on a proactive approach towards compliance rather than a defensive approach. And it's getting together, looking at operations throughout the whole facility, looking at processes and where there's gaps, where there's maybe some risks to the facility, and rating those risks on how likely they are to happen here, and then creating audits or actually creating workflows to bridge those gaps, and then auditing, the workflows that we put in place to see how successful we are. Compliance is working with everybody, in the facility to help them stay in compliance and keep the facility safe. So the compliance plan is saying pretty much all of the components of the compliance program that we're still going to be working through, like getting our conflict of interest updated, our code of conduct updated, training employees, making sure that we have that annual review of what's expected of them in, like ethical behavior and being, to move forward our compliance program.
So, most of this stuff, where did you get all this from, the compliance plan? Where did you get it from?
I took this document, which I think you guys got a copy of in your book,
Right.
and it goes through 7 elements of an effective compliance program and what you need to have in your compliance program to make sure that you have an effective plan. So I kind of just went through this to figure out what we need.
And then, do we have an employee handbook?
We do, and we're going to be updating it. Jim gives it out to every new employee when they come on board.
Okay.
But we are going to be looking at it to just update it a little bit to match our plan.
We also have a code of conduct that they hand out. Some of it is duplicated in both, but one stems towards conduct in terms of handling employees and handling other staff, or other members of the staff, and patients, and visitors. The whole thing is more about the code of conduct. The handbook mostly talks about what we expect.
Do our contract employees get those as well?
Do our contract? No. Do they get the code of conduct?
The handbook,
No.
they will be moving forward, and volunteers.
But how do you know when HR, for instance, it says, conduct reference checks, or criminal background checks of all candidates who offer employment? Would that not be HR's role?
It is.
It is a first one.
But it doesn't specify that they're doing it. That's my question. Of course, I'll tell you later, but there are a couple of errors in here that you'll want to correct before you publish.
Okay.
So, and the answer, Dana, for that is, audits, go ahead, talk about the audits.
The audits they will come from the risk assessment, which the compliance officer wouldn't be performing the audits, it would be other individuals. So this whole plan is a team approach. It's going to take the whole facility, and so it might not specify who's doing what in that document, but Seneca as a team will be performing, the audits on our gap analysis, our risk assessment. HR would be doing the background checks. Med staff does the monthly sanctions checks to make sure that none of our providers are on the sanctions list. So it's a whole team approach, this whole program.
And that's in here, because you have a committee too, don't you, a compliance committee?
As soon as this document gets approved, we will be putting all of the pieces that it's named in this document into place.
So, the compliance officer, who's the compliance officer? Is that you?
Yes.
Okay.
And primary, Linda would be secondary when, they teach us that if there's a problem with the compliance officer, there should be another person that all employees feel comfortable to report misconduct or whatever they feel is an issue to another person, so that's why.
Okay, but it says here, the compliance officer will report directly to the chief executive officer, which is the,
So what will happen is if there's an issue with me, then the compliance officer goes straight to the board. If there's an issue that I need to bring to the board, the compliance officer brings to me and I bring it to the board.
is this spelled out in here?
Yes.
And then who is the quality improvement coordinator?
Casey and Ashley.
You have 2 of them?
Well, I think it's gonna be more Casey, right?
Yeah.
You're gonna be going to, yeah.
Okay. And then as far as the departments go, are these just the standard hospital departments,
Mhm.
so there's nothing new there.
No, no.
And then will this committee have regular meetings?
Yes. At least quarterly, more often if needed.
And then that committee has to report up to the quality committee, who has to report to the medical staff committee, who then reports to the board.
Those are all my questions. Any other questions from the board members?
Seems like it's gonna be a really big program for our little facility. I guess my only question is whether this is something that would make sense to see if we could partner with another entity to help us do. Because it seems like a lot of stuff to put in place and a lot of bodies needed for it.
I think the problem though is if you make a mistake, it can be very expensive.
That's
Really expensive.
And to help answer that question, Veda, our liability carrier, will help us with the compliance program. They're very active with that as well. Unfortunately, even though we're a small facility, we have to meet all the regs, even if we were a 3,000-bed hospital. They don't care.
for sure. No, my question was whether it makes sense to try and outsource this piece rather than try to do it all in-house. That was my main question.
Okay, and so Beta will help us, so we don't have to outsource or we have that expense. We already pay Beta to help us, so they're gonna help us with our compliance program, because there are liability carriers. So if we have a compliance issue there, they actually have to help us back up anyway. As far as the rest of that piece, it'll tie right into our quality. It is very expensive, but it will tie into our quality programs that we're already doing.
Are we gonna be pulling bodies from other places to work on this, or having to hire more bodies to work on this?
No, the quality piece, we're already doing the audits. We'll be doing additional audits. So you're already doing some of the audits that we have to do for compliance because of quality. So you just add 2 more questions to that checklist that the quality people are looking in their records. Or I'll use Pat and that stuff. She already has to do those audits for the sanction list. So when Sadie as a compliance officer will go this month to Pat and say, show me your log. It's just that one more step. We're already doing a lot of this stuff. It's now show me, I need to see that log.
So we're not gonna be moving people from other work they're doing to doing this work.
Part of what we're looking at right now during this budgetary process is a complete looking at are the right people in the right jobs doing the right job. So do we have people doing jobs that maybe we can add something else to them and be more streamlined for them? So the answer to that is we're looking at who's doing what right now during this budgetary process, and do we have the right responsibilities? We don't want anybody walking away from here saying that we're laying people off or that we've got the wrong people in the wrong jobs. It's not what I'm saying. What I'm saying is, are the jobs with the responsibilities correct? So I can't answer that. Are we bringing on more people? I seriously doubt that. And you already have my head.
Well, I'm not worried about that, as I am worried about people having too much work piled on top of work they're already doing.
And that's what we're looking at right now, because we know we have people, and I could probably name people right off the top of my head who are already doing too much work because they're the doers.
Right. And that's my concern. We don't want burnout.
Well, and that's why we're looking at the budgetary process right now. Who's in what places, what position control numbers do we have, are they where they're supposed to be?
So you'll have a better answer for us next month.
Well, after we do the budget, yes.
So do you want this plan approved today?
We really need this plan approved so we can move forward with this, because this is one of the risk assessments we found is that we don't have, we have a compliance plan, I shouldn't say we don't, because they found it, but it was from 2000.
19 something, 19,
Yeah.
99.
Yeah, it's really old, so we need to,
So we're replacing it with this one, right? So that's how we need to make our motion then,
Yes.
right? Yeah.
And of course, this will be revised periodically, I would assume.
And
yes,
we'll
it's a
be-
living, breathing document, so, as rules change, we have to change the plan.
So I'll move to approve that,
Okay,
To
motion.
replace our current.
to replace our current compliance plan.
Is there a second? Okay, any discussion? Gary? Vote. Dana? Aye. Ken?
Aye.
And I'll vote aye. Okay.
time clock and attendance, Jim, do you want to do the time clock and attendance one? I'll say if you
Sure.
want to. I can.
Sadie probably will.
Okay.
I approved it all, I read it through, I know more about the attendance one. I'm wondering, why did we put it as new? Because
We never had an actual attendance policy, it was all an MOU.
yeah, so we actually put it.
The time clock and time reporting, we revised that one. We had a previous policy that stated if you clocked in anywhere from, say you were a 7 a.m. employee, and if you clocked anywhere from 7 a.m. to 7:14, it would push you back to that 7 a.m. time. So people were using the district for 15 minutes of time quite frequently. So we pushed it back to a 7-minute grace period, so now they have to be clocked in by 7:06, and then it would push them back to 7 o'clock. And you agree to that?
It was already in the union book, it was a 7-minute rule for the clock.
That was the first one I was reading that.
Yeah, yeah. We actually were taking our policy and mirroring the
Yeah.
union book.
Thank you for that, because I was really surprised. So that is what that policy is revised for. And then the attendance policy was actually, we never really had a Seneca healthcare policy. We were just using the union MOU, and so we just created this new policy to mirror the union MOU on attendance, and it talks about how the employees get occurrences and when you start the progressive discipline process if attendance becomes an issue. So for your revised policy, you have a tracked policy showing what we changed with, and one where we accepted the changes, so it just looks cleaner. And then the attendance policy, there isn't a tracked one because it's brand new, so that's why you have all those weird papers.
I guess my only question would be kind of an aside from this, just how do we ensure that these policies are fairly and equally applied across all departments and all employees? I guess maybe that's a math question for Jim.
It's a good question.
Yeah, I know it's a tricky one too, but that's why I'm asking, because it seems like a pretty important one.
I will tell you that some managers may be more lenient than another manager because of the situation, the circumstances, everything is different. And, you know, some people are very strict about it, some people are a little bit less strict about it. But in general, if it's something that an employee is abusing, then it's definitely across the board the same. But if it's something where somebody has an emergency, okay,
Sure,
we're giving
yeah,
a bit.
things come up here or there, but if there's a consistent application of a different set of rules to some people than other people, do we know that?
I wouldn't say it goes to that point. It doesn't go to that different level.
So with the compliance plan that you guys just approved and the compliance program, it will allow us to more evenly hold managers accountable, to hold their people accountable. So it all kind of ties in together. So,
Is there a monthly periodic meeting of the managers along
Yes.
with?
Twice that one.
I mean, I'd like to think that as those managers meetings, these issues of internal consistency are discussed. There's always a subjective piece to this, but having that discussion, make sure everybody's trying to have the same application.
right, yeah, that will be on the managers meeting agendas too.
Well, I guess we're waiting for another motion.
I'll make a motion to approve all three of these. Three or two? Yeah, one's
There's
just
two,
like-
I gave you the track.
Oh,
And the
and
track.
the fact that,
The two policies.
I'll second.
Time clock reporting and the attendance policy.
Okay. Motion and a second. Jerry? Dana? Ken? And Albert? Okay. Capital improvement plan. Steve, do you want to?
There's really no change from the last month, so
Looks about the same.
the big thing is that as we go into the budget, we'll be working on the capital budget as well, so stay tuned.
Thanks for keeping it in front of us though.
Right. Was everybody able to find theirs?
Yeah,
It was filed wrong. Did you get it?
Yeah, I got it.
Okay.
education.
So, I was not able to go down to the ACHD ledge day. We had some issues here that required me staying and not going. So I sent Lindsay instead, SPR marketing. So Lindsay, do you want to report on that, please?
Yep. So I had a great time at my first ledge day. You really learn a lot about yourself when you go to something new to you and get thrown in with a bunch of people that you have no idea who they are, but they all seem to know one another really well. Val Leakey from Mayor's Memorial took me under her wing, showed me around, let me sit with her, learned a ton from her. So I'm going to keep it brief. I'm going to just talk about a few bills that we discussed kind of at length and a couple topics, and then that's it. Our guest speaker was Cecilia Aguiar-Curie. She's the representative from the Winters District. She spoke to us about a constitutional amendment, ACA 1, which, if accepted, would create a new threshold for approval of bond and tax for infrastructure and housing. It would move from a required 2/3 vote down to a 55% majority. This change puts housing infrastructure projects on par with school proposals so that cities, counties, and special districts have a practical financing tool to address community needs. And let's see, it would ask California voters to approve a reduction of the vote threshold for the approval of bond and special tax measures for local affordable housing, supportive housing, and public infrastructure, which is where our special district would fall in. From a 2/3 vote to a 55% majority. So that was, she was our guest speaker, so that was like an hour conversation of what she's trying to push through. The other,
What kind of thoughts did she have in terms of the likelihood of that passing?
they felt confident. They were waiting for, sorry, go back to my notes. It needs a 2/3 vote in Assembly and a 2/3 vote in the Senate to pass. They feel confident because it's the same voting threshold that currently applies to all local school construction bond measures. So they're trying to streamline it across, so they felt confident.
Any rumblings in the governor's office?
I'll get to that. The next one, which would be huge for us, is, these are just the few that ACHD talked about that they're in support of. AB 890 authorizes practitioners to practice to the full extent of their education and training, granting NPs full practice authority. It expands NP education and reforms the scope of practice regulations so NPs can achieve full practice authority after a transitional period of collaboration with a physician. There's also SB 697, which essentially does the same thing for physician's assistants, allowing them to practice to their full extent of their education and training without supervision of a physician in specific circumstances and settings. And then AB 8 requires schools to have a mental health professional on campus for every 400 students, which I don't think quite applies to us.
Not unless they count both campuses.
Yeah, so and they didn't talk about situations where smaller towns and areas. We then had panel discussions, and a big portion of the panel was discussing what it's like under the new administration and how there's a real uneasiness currently because everyone's trying to figure out where Gavin Newsom stands on things and what kind of bills he's going to support. He's currently he wants something big and he wants to make a name for himself and he's trying to build his brand. They think it's going to be kind of uneasy for the first couple of years until they really figure out and the dust settles where he does kind of stand. They're seeing a lot of bills that have been unapproved by Schwarzenegger and Brown. Just no changes to them. They weren't approved there, and they're just kind of throwing them back through to see, hey, maybe he'll accept this one. So it's kind of like throwing noodles to a wall is what they said is happening right now. So, yeah, it doesn't make me feel very good. I think that is all I have. It was a fast and furious 24 hours.
Thanks for that.
Thank you.
Okay, HRG,
I think we also discussed that as well, unless there's any questions.
nothing else there? Nobody has anything to add there, do you? Okay. Committees, bylaws committee,
I also sent our bylaws that we're working on to attorneys so that they can give us some input as well.
no, I thought we were gonna have an overhead projection presentation, Jerry, did you say that?
Well, that up the we're going to.
What's that?
We were gonna project overhead, I think, but we never heard.
Yeah, I'm ready when you are.
No one ever, no one contacted me on it.
I guess we were both kind of waiting to be contacted.
Okay, so let's make some definite plans on what we're gonna do.
We're in the same situation with this as the other one, we're waiting for feedback from the attorney, so. Okay, what the attorney says.
It makes sense to go through them once and not jump twice, right?
Right.
Yeah, I think that's what he's getting at.
Then do you want to make a presentation with the overhead projection or?
I do, I think it'd be a lot easier for people to
Then why
see it.
don't, when you get it back, you copy to Jerry and then you can get together with Jacob,
Mhm.
put something together.
Yeah, just send me the
so
copy of
whenever
whatever.
you get feedback, if you can send it to me, copy Jacob so he knows that I'm gonna update this document and then we can get it together.
Jerry, I'll just need the final document so that I can project it on, or whatever you
I'll
have.
just bring my laptop in and we can see if it'll work with your projector. Might
Yeah.
make it easier.
Might make it easier.
Okay.
So one of the
Well,
things,
I'm sorry.
one of the things that we're gonna have to do, I'm sorry, Ken, is that we have to completely retype those bylaws because even though we tried to convert them off of whatever program we were using, it didn't convert right when I sent it off to the attorney
I already completely retyped these like,
onto a Word document.
pages and Open Office and Google Docs.
See, that's the problem, is that it had to be on a Word document to convert it to our system. I can't get it to go right. We've had Lindsay tried, Michael's tried,
It's
so.
not downloading as a,
I was able to convert it from a PDF over to a Word document, but do you
well, but
run on
I
a
had,
Mac?
I had a non-PDF version of that, a Google Doc that can be downloaded to, did you try that one?
No, because it was
Yeah.
read only.
One we have is for you.
But I could always take your pages on my Mac and just turn it into my Word document would be okay too.
Mhm. I didn't
So
know
we
it
can get
was-
that done, then we wouldn't have to, that would be fantastic. 'Cause
Oh, I know,
you
but I
guys-
spent hours doing this.
Is the question, is the attorney going to add language, how is that going to be captured?
He will, I sent it to the document that we changed off of what you sent, that you had on PDF, and Lindsay took it from PDF onto a Word. When it came off of Word, Michael had to change some of those box changes and update that language and then send it off to him.
I'm just trying to just make sure we don't have to pull out different documents.
Well, we shouldn't have to, because I mean, I had said if you log into Google Docs, you can download a Word document version of this. You don't have to do all these conversions and.
Our system won't let us do it.
Yeah, the one we have is view only, first of all, so we can't do anything with that. Did you find out?
I didn't have the Google Doc.
Lindsay, we can test it. Why don't we test it?
Yeah, I'll give you my email and we'll share it, yeah. Correct,
Thank you.
online.
So somebody can make.
Yes.
Well, I just hate to see stuff get pushed off.
Yeah.
Okay, strategic
Yeah, I think we're all
planning.
tired of seeing bylaws on here.
Well, you put a lot of work into it, you should bring it to a conclusion here. Strategic planning committee,
So we had a meeting last Thursday, and we talked about, that survey model being almost completed, and that will be helping us to evaluate space usage. We had, the Woodley feasibility study should be in, the first part of it should be in mid to late May, as well as the Aspen, assessment master plan. The good news I want to give, and I put it in the middle, is that Collins Pine did, they went out there and flagged It's like about 12 acres, NST is going to be completing the survey so that we can get the 10 acres within the 12 acres. We had a map, did we bring that map with us? I didn't know that map. There's the map that Collins put together for us, that NST is going to survey the 10 acres for us. So we're moving fast and furious on that. So it's going along quite well. That's it, I was trying to go fast.
I'm sorry.
Upstairs from Model 2? Did I miss that one?
Yep, you did.
Sorry.
Are we moving forward with it? So I said, that, I'm sorry, that was, WIP is gonna help us with evaluating space usage, so that's a part of the feasibility study.
So we're not doing anything on it right now?
Right now, it's not finished, completed, we will get it completed, I think last told me in the next 2 weeks, and then at that point, yes, we were moving the AJM upstairs.
I'd like to add to this, we had two members of the ARPD group at the meeting, and it was really neat to see Linda have good discussion with them about how the two groups, our group and theirs, can find cooperative measures for the health of the community.
What was the second group?
ARPD, Elmore Recreation.
Oh,
And it was about the trail.
yeah, I was gonna ask if that had come up.
It did, and they're quite happy with what we talked about with the
Shouldn't
land.
impact the trail.
Exactly. In fact, they were really pleased that we're looking at using that area over there. So it was a fantastic discussion that we had.
Okay, you wanna just transition into your CEO?
Sure. I'm going to talk about the skills assessment because I'm really excited. Skills survey, I'm really excited about that. We had this date here. They surveyed for the licensing, state licensing, CMS, which is federal regs. So we got the two surveys in one over with. Very minimal findings, and what they did find were really fixable things. So there was two issues about bed rails, and it was about we had two residents that have been here for, I want to say, over 10 years, that the consent for putting the bed rails up, we couldn't find it, so we need to fix that consent. And then there was a new rule about if you're using bed rails for assisting device, you have to do an inspection on the bed rails. Well, we didn't have that law, so we'll get that fixed. They will continue to give us our RN staffing waiver, and what that means is that we do not have to have an RN 7 days a week on day shifts down in skilled. We can keep the 5 days a week down there. Although rumor has it that that staffing waiver may go away in the next couple of years, but right now they told us they're going to go ahead and suggest we keep it. There was a pharmacy piece about tracking of the discontinued controlled substance meds. They wanted to see a separate tracking log than where we had it. There was an issue on infection prevention about the linen storage. It wasn't 6 inches off the floor, it was only 4 inches, so we fixed that immediately. There was an issue about isolation not being implemented for residents. There was an issue that we have 3 residents that there was a change in how you give the pneumonia vaccine. We have 3 residents that only received 1 of the vaccines instead of both of them for CDC guidelines. That's being fixed. There was an issue, and I think, Jerry, you brought it up about the contract staff files, and are they being oriented and evaluated the same way? So there was an issue about the orientation to the unit, not to the hospital, but just to that unit, that they would see the checklist for the agency. So we're working on making sure that happens. And there was 1 or 2 of the contract files where we didn't receive all of the information that we needed on that employee, the contract employee, because we have to keep those files just like we keep our regular files. That was that side. On the state side, we had an issue that we had an expired insulin pen in the med cart, so that was an issue. And then They re-cited again, because they do this a lot, on that controlled substance tracking. State cited us on that as well. In addition to that, they also cited us on the discharge meds were in a area in the Pyxis that wasn't clearly labeled discharge meds, the little drawer, and the meds themselves weren't labeled discharge, or, yeah, discharge. Then there was an issue about the emergency kits in skilled, and this is something that even the surveyors themselves thought was ridiculous. In the regulations, it says that we can put the emergency drugs in a tackle box. So this is, just a regular fishing tackle box, and we don't do that. We have the E-meds in the Pyxis system, which is this huge ball-like system. Well, they didn't like that. They were supposed to have it in the tackle box. And then the other issue was that the label wasn't on top of, well, it said tackle box, but the Pyxis system that said what those E-kits or emergency meds, sorry, for the skilled. We didn't have the log on top of that, so that was an issue. I told you about the controlled substance. Then on employee health, 2 out of 8 employees, we couldn't prove TB testing, although we know they had them, we just couldn't find their forms, so we couldn't prove it. 1 out of 8 employees, the employee was supposed to have a 2-step TB test, only had a 1-step. Then on the physicals, we're going to have to take this to medical staff because the medical director of skilled now has to sign off on all the physicals, sign off on the physicals. They're not just signing off that the physical was done, they're signing off that the employee is physically able to work down there and that they don't have a communicable disease, so they have to look at TB testing and their vaccination records. So it's something we're going to have to discuss with the physicians over the added workload for that skilled nursing medical director. And that was it. We got no quality of care issues. We didn't receive any dietary issues. We didn't receive any medical staff findings. What are some more hot spots? Medical records? No medical records issues. So this was a fantastic survey. We had one surveyor come in the first day and she, due to health reasons, left. We had a second surveyor come in the second day who knew us, was here, surveyed and went home. And then 2 surveyors who were new to the survey process, so we helped guide them through as well. But they were tough because they're new, and so they were by the book. And if it said that Dr. Ware needed to wear, or Dr. Wall needed to wear a red tie, you better have a red tie. They were that by the book. So we were really pleased with our survey. It went well, great team, everybody worked hard to get all the information. They were really pleased about that. They were pleased that they didn't have to go hunting for information, that everybody was pleasant, that the residents loved it here. It was just a fantastic survey. So with that said, Pat, I'm going to let you talk about recruitment and providers because we've got some exciting news there as well.
We do. So, like Steve was saying, that our nurse practitioner cost is high. We are in like our final negotiation stages with Stephen Hayden for a permanent buyout. We are in beginning stages with Teresa Nielsen for a buyout as well, and they're both nurse practitioners. Then we have Dr. Ewing, who worked here last year in family practice and an ER physician, who wants to come back for a few weeks in the summer. I've ran this by Dr. Ware, Dr. Walls, so that they could get some vacation time possibly in there. So she will be joining us towards the end of May for a few weeks. We also have 2 good-looking permanent candidates that we are just waiting for dates and times that work next week to have a physician interview by phone, and then from there, depending on how the medical staff feels, we would invite them up. So maybe some new exciting things going on, and lowering costs again, which Steve likes.
So, IT assessment, that's still ongoing. I talked with, Linda Manji, who was looking at the infrastructure. He has to give me a estimate on what it would cost to get him up here. He was referred to us from Jim Hallenstein and Rich Reddow. Otherwise, IT, they're gonna talk to you a little bit more about some of the things that they've been doing. Liz did an assessment for me. She came in and helped him with doing some of those changes that she talked about. So that's still ongoing. The Home Family Trust donation, Home Family gave us $10,000. And it's at board discretion for how we're using the funds in a patient care manner. So we have that letter that the attorney gave us.
Linda, I'm not familiar with that. Could you just tell me what it is?
Yes, we received a letter that apparently Dorothy Coleman died on January 5th, 2019. And the family, she set up some trust funds, and one of the trusts was for us, that we were to get $10,000 from her from the trust fund.
Who was she?
Nobody's really sure.
Did she live around here?
We're not sure.
I'll find out if she lives in the club.
But her name is Dorothy Coleman, C-O-L-M. And this trust fund dated back to September 1918. The provision was that Seneca Healthcare District had to be viable and in corporations to receive it.
And then what we're supposed to use it towards,
It's patient care, and it's to use in the discretion of the hospital's board of directors. The foregoing gives is to be made by the trustee or the trustee. Sorry, patient care is care. This is just $10,000 at the discretion of the hospital board of directors.
so,
Copy of that.
Yeah, I have a copy of this.
will you bring a recommendation to us for?
Oh, yes, yes. We were just excited. Yeah, $10,000. Yes, so you can have on the next agenda. Then, okay, so the complaint, we had, Smith DON. So Roseanne put in her 2-week notice a while ago, not a while ago, what, 2 weeks ago. So today was her last day. What we looked at is who did we have in-house to do the interim, and we had a couple of candidates, but Ashley so graciously accepted to go down and be the interim Smith DON down there. Ashley has experience in the skilled nursing side. She was a skilled nursing LVN, so she meets the requirements of a Smith DON. So she's going to be down there interim for us. We're hoping she loves it down there, wants to stay down there, although I want to get coordination too, and that's to Jerry's point that a lot of people are doing a lot of work.
I'm sorry, Liz Roseanne, where is she going?
She's retiring.
Oh, she's retiring.
That's what I got told.
Yeah, but she's old enough to retire.
It's a financial decision, not an age decision.
So we also had an official compliance complaint. It came rather timely for Sadie and I. We had been talking about it, and this came from the Office of Civil Rights, and what the complaint was about is our admissions office, and the issue was HIPAA and the admissions. So that was one of the reasons why that we were really looking at, all these different moves, and how are we going to move out the desks so that there's only one person in admissions at the time. It was something we thought was going to happen, and it actually did. We did get the official letter. So we did, what this letter states is that if we, let's see, where is it? Let me find it. have no further complaints in 6 months. OCR may initiate a formal investigation of the matter, but please note that after a 6-month period has passed and OCR has not had any complaints, they'll consider this that we've taken action and the OCR is closing the case without further action. So we needed to make a change, which we're doing now, and then we'll have 6 months of no complaints to the OCR, which is the Office for Civil Rights. Then they'll consider the matter closed.
So is this a patient, did they approach you first, or did they just go directly to make a formal complaint?
They went directly to me.
So, just as process, is there potential for fine at this point, or is it only if there's an additional complaint?
There is no potential for fine on this complaint. There would be a potential for a fine if there's another complaint. So, and that's why we're making that move. That's what we're doing, so that there's a big impact.
What type of fine are we talking about?
Say miscompliance, fine for HIPAA violations.
Up to,
Up to and
Up to,
including.
up to 250,000?
Yeah, the minimum is 15, and then up to 250 plus there could be jail.
Civil
And it
and
could
criminal.
be not only facility-based, but it could also go personal-based if there's one person missing. So it could be at the 2 different things.
So we also had a complaint regarding a hostile work environment. An investigation was completed. That complaint was resolved, and it also, the action for that was that we're bringing in some training on April 30th and May 1st for all employees. There's 6 opportunities that they have to come to us mandatory training on.
The first and 30th.
Thank you.
The 30th is
I
the
said
first.
that, 30th and 1st. It's on preventing hostile work environment, being respectful of each other. So let's see, possible,
That was brought directly to.
that was brought directly to us. That was not filed anywhere else. The complaint was just, it was more of a grievance than a complaint, I should say. And it all stayed internal. Possible week is the week of May 16th. We're going to have a barbecue on May 16th. And it'll be tri-tip, and we also will be having the awards at that time. I do want the board to know that I received a letter in the mail that I have jury duty on May 6th, and I'm the lucky one that it's a possible 28-day trial, and it's in the Superior Court. So I've used up all my, I call them get out of jail free cards, so you don't have to go to jury duty. I missed out on the week 1 and then the 2-week one, and anyway, I have to go to that. So I will go in on May 16th, plead my case, and hopefully get out of that 28-day trial. July 4th, we're going to have a presence in the parade. Lindsay's going to be spearheading that, so you'll be hearing more about that, but we will be in that parade. The KDK grant, we're looking at getting that submitted and having all the lab equipment. Lab is pretty much, with Dave's not in here, is he?
He's working.
Probably about 75% of his equipment is end-of-life equipment, so we were looking at using that KDK grant or asking KDK folks to help us with that lab.
When's the deadline for that grant?
Next week. So Dave's putting it all together for us, and we're going to get it sent off. The Vader refund, we got $67,000+ for our dividend, and it's from our medical malpractice and our work comp. So we got dividends. We did really well by not having a lot of cases and got money back. And then on the prime grant, I was asked at one point, the board wanted to see what we submitted for the prime grant. So that's what's in there for you under tab M. This is our mid-year report, and this is what we submit. So this shows that we met all 5 of the metrics. Ashley, Casey, and crew has done a fantastic job of making sure we got submitted timely and we met those metrics. And it shows you what the metrics are, all cause readmissions. And in here you can see what we submitted as to what some of our challenges are and what some of our successes are. So that's in there for your perusal. And then I wanted to say that we did get the information on the SHIP grant. So that's $48,000 over 4 years that we applied to and applied for and we received. So we sent all that paperwork off. So that we'll be getting $12,000 a year. We'll be getting that as well.
And what's that one for?
The SHIP grant is, it's a quality grant. It's for quality and it's for some finance. We did it for finance education. Last time we did the SHIP grant for
The estimator.
the estimator, so that when patients came in, we could estimate what our, how much money it would cost them. So, yeah.
This might be a silly question, but where it says on page 2 of the prime thing, it says prime eligible population 0. That kind of makes me worried.
So actually, you wanna,
I'm sorry, say that again?
It says prime eligible
It
population
just
0.
isn't in there yet.
You
It's
probably
in there
don't
now.
have the updated copy.
It's in there now.
Okay, I was wondering because it was a draft. She said it was submitted, that's why I.
It has been submitted, but it is in there.
It's in there. We can bring that to you for the next one.
Is that DY 14?
In
it's
here.
the one that, it's
Yeah,
the one
it's
that you just
16.
about this morning?
It just doesn't have any values in it, that's why I was, I don't know.
We can bring it, I'm not sure.
It's like 1624 or something like that.
So that's all I have.
Thank you.
You're welcome.
If you were gonna look up what I saw on Yahoo about the new Medicare rules that are going into effect on the 1st of 2020.
Yes, I was, and I left my notes in my office, so I can do a summary and send it out to the board.
Or you put on your CEO report for the next month, however you want, whatever the board wants.
Yes, thank you.
Okay, we'll move along with the department issues, reports. Casey?
So we don't have anything right now. We just got done with crime. We're working on a few other things. I'm losing Ashley, and I'm not a one-man dog and pony show, so I get Heather now. Ashley's just filling in for 3 months down there, see if she likes it, get her feet wet. I've done that before. It's Ashley's turn. So we'll pull Heather. She's a per diem RN. She's going to come in part-time with me and help keep the quality piece moving along with the compliance stuff. We are still looking at doing a CNA class. They are planning on opening that within the next couple weeks at FRC. Judy, yeah, it's for the fall. So hopefully we have Pam Valencia coming in to help mentor actually. We've had Pam for multiple years. She's an ex-surveyor. She's with social services now, so she can help us again. So we have a few questions about how Ashley can teach, still get those CNAs through, but we are doing another class in the fall. So.
And then last board meeting, we had a couple of questions about the NRC survey system. There was a few patients that had multiple visits at different departments, but apparently the survey wasn't identifying which visit the patient was referring to, or the visit that the patient was in. So we have a new rep with NRC, and he's looking into these complaints, like people that want to be removed from the list, or too many calls with one visit, because it's up to 3, but some people think it's way too many. So we have a standing list, and he is looking into changes and some possible different avenues for us. So we'll get back to you on that as soon as I hear from him.
Thank you.
If someone gets a call, they don't answer, and is a message left for the phone number they can call? Okay, so yeah, maybe.
And then it's gonna call them within 24 hours again, and if they ignore it again, it's gonna call the final 3rd time.
Yeah.
On top of email.
Yeah, 3 doesn't seem like a lot. Are we texting them too?
No, just email and telephone. But if somebody comes to the clinic, say they saw Dr. Walls and then they got an x-ray and then randomly they went to the ER, that's up to 9 calls plus email plus, so they're kind of overwhelmed.
We are getting patients that complain about the call.
Yeah, there's too many, because they're getting hit for every direction.
And then if they were in house, they're getting HCAP, so that's a lot.
Okay, is Karen's not here?
No, but she gave me her update, which wasn't much. She helped, work with the skilled nursing facility and between, no, look, don't be me.
Kids pick up.
She, they're shuffling around the folks, the quality, the care coordination department so that we can cover skill. And she's also working on, looking at getting a weekend supervisor. That's one of the issues that we have, is that we don't have a supervisor person for first thing on the weekends. So we're looking at that as well. And then we gave you this skilled update.
The supervisor is not an added position, they'll still do their shift. There's just people who work on the weekends, but they'll be the one to report it to. Just so we know.
Appreciate the clarification.
Yeah.
And do you have a report?
I didn't have anything unless you have questions for me.
No. Anybody have any questions?
I was just wondering how our telemedicine is going.
We're holding steady in numbers. Right now, we haven't seen a big influx. We're trying to fill with providers that we have. But we're holding steady, getting the few results.
I haven't noticed, do we have an ad in the paper that talks about telemedicine options?
We've had ads and we're kind of just rotating. And then we did a big article, actually, was it in, we're in April, it was in last month was the telehealth because it was wrapped around their 1-year anniversary.
Yeah.
And a little write-up in the paper for that, but they also have a radio ad that's running. Currently, we have a sniff ad running, but then that will come down, it's almost at its end, and then telemed will go back up. And actually, we got a few patients from that radio ad that came in and said, I had no idea you had this, I heard it on the radio. What?
For the telemed.
For telemed, from the radio
That's what I
ad.
was wondering, is if we're getting.
Yeah. Yeah,
Thank you.
so that was next.
Can I ask just a quick question about that? How much resistance are we getting to the use of telemed? Any?
What kind of business?
Well, just patient resistance, I don't want to talk to a doctor in the box. Any pushback at all?
I am only aware of one person who wasn't aware that telemedicine was via a video chat.
Yeah.
But otherwise, I'm not hearing of any resistance to it. It may be at the provider level where they're asking not to be referred to telemedicine, but they want it in person, but I'm not aware of any.
I'm just curious about it, and if that's out there, what strategies you might have in place to address that.
I haven't heard any, actually. I do sometimes hear when I'm out and about different things, good and ungood, bad. And that one has not actually come across my desk,
You know,
but I'll
fix
listen
it
for that
yourself,
one.
right?
Yeah.
All right.
Well, most of your cases are referred from doctors though, right?
Correct.
So, I mean, we prepare the patient for it, so there shouldn't be a big mystery. TK, did you have a report?
Just that we're continuing to develop the video program for learning that's provided by Evident. It's called CPSIQ. And it basically will provide the users with a baseline introductory level as far as navigation and kind of how the system works, and then we'll go with them and do one-on-ones to point out, how it might be different or customized for our site. We're getting ready to move to the updated EMR this year, so we have plans for that. And then just as we continue to work with providers and staff on enhancement requests, just staying current with different things as far as documentation.
David?
So, I'm very pleased to announce that our telemetry system that we put in here not too long ago is live with interfacing and sending live patient data back into our EMR. The vital signs that are recorded are now date time stamped digitally, and the physicians in the ER or even on the floor when you come in to review, you have the ability to import all of the correct time and date of any events that happened. If you have them on like hourly vital signs, if they're under observations, those are all automatically now synchronized with the patient's chart, and your physicians, your nurses, everybody can see that live update as it goes. And currently we are collecting proposals and for our annual HIPAA risk assessment for the IT infrastructure to go with the IT assessment that we've been currently working on. And that's all I have.
Thank you. Lindsay, you want to?
Yeah, so I already talked about Ledge Day, which was awesome. Small chamber update. Last meeting, I told you that the chamber was looking to hire an executive director. We hired Chelsea Outland. She's fantastic. She's she is helping to relieve the stress of the board of directors so that we have somebody to coordinate our events and really get their hands dirty. I actually met with her yesterday about the golf tournament and some other stuff, but she's a huge asset, and I'm excited about that for the chamber, but also for the community, for what she brings. With that said, our chamber golf tournament is May 18th at Bailey Creek Golf Course. We're piggybacking on Bailey Creek's opening weekend, so we should have a really good turnout for that event because it's the first Saturday of the season for them. My husband assures me there will be no snow left on the golf course, and we will have that tournament.
The hair dryer.
Yeah. Yeah, I'll be out there the night before. Annual membership dinner is June 1st, and that is a wine and dine, so it's wine tasting and dinner. It's at the rec building. Starts at 5 o'clock wine tasting, 6 o'clock dinner. How we've usually the last couple of years with the golf tournament, the membership dinner has become a part of the tournament, but this year they separated it out into its own event with sponsorship opportunities, and
They tried it that way last year.
it didn't work, and that was one of my notes on that. Linda touched on the 4th of July parade, but Seneca will have a presence in the parade this year. The theme is Come Together with the Mountains, and if you don't want to decorate your float towards the theme, it's a good red, white, and blue. So should be a really good, exciting, I don't know if I'm allowed to say what's happening in the parade, but it'll be a really good parade to go to. So we're excited about that. Linda talked about Hospital Week. I've invited the paper to come to take photos so we can recognize what Hospital Week means to us in the newspaper, as well as an ad that will go out. And then I'm working on a facility-wide Biggest Loser Challenge, which will be May 6th to June 24th, a 7-week stretch. And I'm just trying to put together some lunchtime walks or some meetings if somebody wants some additional support or just to talk or have lunch together or something like that. That's the part that I'm putting together right now. So that is all I have. We also are sponsoring again the Courage Triathlon. We want to put our team together before we make sure we have our team together. We've had to change it a few times. Biking, kayaking, and running. So if anybody wants to bike, kayak, or run for Team Seneca, I'm taking volunteers. That's all.
You can.
Yeah.
I was just thinking, I did that once, and remember I had the canoe section, and I ditched,
We came in second last year, so we have some little bit of competition to uphold.
Jim, you have a report?
Yeah, not too much. We've added a part-time staff RN. She's actually someone who lives in there in Chester and has finally come back to the fold. And an HIM admissions tech person. We have lost a part-time HIM admissions tech and a full-time Generations Tech. The housekeeper was not discharged, it was voluntary, I messed that up. And as you know, Roseanne said, DON is leaving. Under conditional additions, I didn't have Pamela Lynch, who's going to come somewhat mentor Ashley in the long-term care. And she actually will be starting next week. So.
Okay, thank you. The consent agenda, this is the first time we've had anything to do with the consent agenda since I've been president. How do we do this?
So what the consent agenda is it's something that there's really no discussion over, it shouldn't be controversial, and that's just, in the compliance plan that you passed, the board needs to appoint compliance officers. Compliance officers should be certified, and as said, Sadie and I both have passed our certification, and what we're asking is for Sadie to be the primary compliance officer and all that for us.
Who grants the certification?
Health,
Rick, I have the pen.
HCCA, who is the Healthcare Compliance Association.
Is that a federal agency or?
Yes, yes, it
They
is.
partner with the OIG a lot, yeah, so they're federal.
So I guess we could have a motion to appoint these two? Is that how you want to do
Is
it?
the motion to appoint these two, or is the motion to approve the?
I don't know, I haven't voted.
Just like the board will appoint, so yeah. Okay, we got a second.
So we do have to have a motion?
Yes.
Okay, so I'm sorry, did someone make a motion?
I think I did.
Is there a second?
I'll second.
Okay, all in favor? Jerry? Dana?
Aye.
Ken? And myself, aye. Okay. Did the ultrasound take Kevin?
She wants to, be next month, so I made sure that, well, Michael did it for me. She'll be on the agenda for next month. She wants to talk about the services that she's doing and how well the community is receiving it and the physicians, and that is going great balance.
And, Michael, do you have
The systems, CEO and sent out the donation is on.
anybody have anything else to add?
Budget.
All right, the bylaws,
Have bylaws
well,
down.
we're waiting to see if that comes
Well,
out.
Yeah. Just if you.
So my last
meeting.
We've got it.
yeah, it's not that one.
Now, just to clarify, Dr. Wells, for our closed session, it should be CEO mid-year performance evaluation, right? Isn't that how we normally word that?
No, it's the first half of the incentive.
I understand what the purpose is at the end of it, but we usually put performance evaluation in there. And I think there were certain reasons for that related to closed session items.
No, you just took it off of the last time that we did it, we just cut it.
What is the question?
Just the title of the topic for the closed session, I don't think it's correct. Technically.
What do you think it should be?
Mid-year performance evaluation. Because when it comes to discussions of monetary, that part of it has to be an open session, so we can't talk about and decide on money in a closed session for a public entity.
So the reason why it says CEO first half of the year incentive award is because that's all you're looking at, is the awarding of the first half of the incentive, that the amount was already decided. So in closed session, you decide upon that first half of the incentive, is that full amount going to be awarded, or is it going to be partially awarded? You make that decision, and then you do the vote in open session.
Right, but that decision is based on performance evaluation, which is an approved item to be listed as a closed session item.
I'm sorry, I have to get into with you on that. That incentive is based on The 2,000, it's because there was not a new incentive, so it's still based on this,
Just on the old.
2017 goals and objectives incentive. That's what it's based on.
Right, which is still a big evaluation, which is my point, which is what it should say. I just want to make sure we clarify that before we go to closed session, because as this agenda item appears, I won't be going to closed session with it listed in this manner.
So you're not doing my mid-year evaluation, you're doing my first half incentive award. That's not the evaluation, it's the incentive award. Rich made it very clear that the incentive award is separate from the annual evaluation.
On the annual evaluation, yes, but we're at mid-year.
This is not a mid-year evaluation, this is a mid-year incentive award. This board has not set up a mid-year evaluation for me. This board set up an annual evaluation, a mid-year incentive award, and then an end-of-the-year incentive award. They did not, this board has not set up a mid-year evaluation. That's why I sent it to the attorney, so that the attorney can weigh in on that.
Haven't we done a mid-year evaluation?
Mid-year incentive, correct?
Correct.
Well, if we talk about whether you met the goals for the incentive.
2017.
Right.
So, whether you, maybe we're dealing semantics here, whether that's, is that an evaluation or is that?
Well, because
We probably need an interpretation.
And when it was discussed, that evaluation is, that my salary is based on the evaluation, the incentive is based on the incentive goal, not the evaluation, which was to your point, that the evaluation needs to have a minimum.
Well, we're looking retroactively now,
Right,
not using
exactly.
the new tools.
Exactly.
So the new tool is to make sure there's a minimum standard on the performance evaluation before we consider we didn't have this very clean line of separation that made us sort of. That's the.
Well, that was what was cost the whole re-evaluation, we're rewriting the whole
Correct.
evaluation, it was very confusing. So, what does the board want to do? Are you not going to participate in the closed session then?
I just don't think that the way it's listed, I don't want the board to get in trouble for going to closed session if it's not written properly.
I don't think, why don't you talk to the attorney and just make sure that we have no liability dangers with how it's done, then you'll have it to back you up.
I don't have a problem doing that. This mid-year incentive, the board chose to change it from when it was originally set up June and December, to change it to March and September. So we're 2 months out. I don't have a problem. I just want the board to be aware, because I was criticized for holding it last year. I don't want to be criticized for holding it this year. So I will talk with the attorney to get the correct wording for the first half of the incentive to be put on the agenda for the May meeting.
And I got confused when you said criticized for holding, I'm not sure what you mean.
Because of the length of time it took to get the different evaluations through, and then the board you couldn't get a date.
You're referring to the process, though.
Yeah.
That's over 2 months later, on the correct process.
That's what I want to make sure.
Right. Okay, so this is not going to be done today?
Well, apparently not.
I can check on the word when we go back to
We
the
have to get these
Well,
done.
this is the same wording that we used last time.
You want me to go pull it up? The last one?
That's it.
So this, I mean, if you would like to see the documentation of what the wording was from last time, that we did have a closed session with this wording, and there was no problem at that point, you can go do that, or if the board chooses just to wait another month, that's fine.
Do you have the minutes handy?
I can go get an agenda.
Yeah. Would you do that?
Yeah.
off base, because I thought I asked if we were going to do that this month, because it was going to the attorney, and I thought, it said, no, we're not going to do it, so I was talking about the wrong thing, is that right? That would be the evaluation for your salary.
Right, because, and again, that was part of that when Rich talked with me, there was a clear separation of the annual evaluation versus the incentive award. Because that was why the board chose to decrease the incentive amount, but increase the salary amount.
So, if someone wants to take a small break, stand up and stretch.
Okay, so 1521. So can we just move forward and go ahead, because I really don't want to be adversarial or arguing over this, so let's just go ahead and move this for next month. Let's make sure it's done
We
appropriately.
can still have the discussion about union negotiations.
Yes, we can.
Okay, and we'll go into closed session to discuss union negotiations. And Michael, get the wording right on the agenda for me. We're on? Okay, we're back in open session. The closed session was for information only. No decisions were made by the board.
And we discussed in the reference to
We only discussed the, let me give you a code. We only discussed code section 54957.6.
And we also talked about having something
Not in
criteria.
closed, not in closed session, we did not. No, we did not, we're in open session now.
I know, but we are.
Okay, so, and we're moving along on the agenda. We're going to set the next meeting date, which is May 30th. Is that correct? Okay. Anything else before we close? You want to bring something else up?
I think we have to have something to use for criteria when we do the CEO incentive program.
Has to be the old criteria.
But
It would have to be the old criteria.
that's all I wanted to know before I